I'm going to talk about breast pathology. And when madam asked me to tell a topic, I thought I will go through the old one and then I will proceed what's happening new. But old is not really old. It's a gold. Without the previous knowledge of what happened in breast, we may not be able to understand the present and future of pathology. So because of that, I just gave the topic title as breast pathology gold and new rather than old and new. So I'll start with objective, introduction, and the WHO 2019 classification of breast lesions. What are the recent updates? Then I will be talking about IHC, massive parallel sequencing and artificial intelligence. Then I thought of doing 1 to 20 cases, but because of the time constraint, I think I will finish it with the 16 cases. And I will be covering the cases including epithelial, fibroepithelial, myoepithelial, and spindle cell lesions of breast. I will conclude with variable points, and I will give you a reference so that you can go and refer. And some of my slides, they will be of theoretical importance. So in those slides, I will be putting this camera sign so that you can take a photograph of it. These are all the three main references. One is WHO Blue Book. Second one is anatomy, advances in anatomic pathology. And the third one is histopathology. The advances in anatomic pathology is from last month, November, or this month, November 2023. And these are all the titles of the articles. They devoted the whole issue for breast pathology, and they talk about a lot of new things. And the histology is from January 2023, and these are all the titles from the histopathology journal. So take a picture of that. Breast lesions can be classified in various ways. For example, clinically, radiologically, pathologically, and in pathology, it is previously only classified with morphological features, but now we have molecular features. And more importantly, now therapeutic classification is very, very important. For example, if you see here, systemic therapy naive versus treated patients. That's one classification. Neoadjuvant therapy treated versus adjuvant treated patients. So these are all the breast cancers. And we have to classify depending upon type of therapy also, whether it is hormonal therapy or cytotoxic therapy or targeted or immunotherapy. So there are a lot of approaches to the classification of the breast lesions. But the most important classification I like is prognostic classification. Whatever we talk for the patient, whether they have a good prognosis, poor prognosis, or very poor prognosis. And this table talks about tumors that are very indolent. For example, pure low-grade adenosquamous carcinoma, tumors having excellent prognosis like a pure tubular and invasive cribriform carcinoma less than 3 centimeters, and a very poor prognosis, which is a high-grade spindle cell metaplastic carcinoma. Like that, depending upon the prognosis, you can classify, and this is very, very important for the interest of the patient. And the treatments available are surgery, radiotherapy, chemotherapy, hormonal therapy. But currently we are talking about targeted therapy, which can be targeted specifically depending upon the molecular findings of the patient. And these are all the milestones for the treatment of breast cancer by chemotherapy. And if you see here, by 2020, we are getting checkpoint, immune checkpoint inhibitors are targeted therapy. And that's what the whole world is moving now. And this is what you will be seeing in future. All breast cancer, ductal, lobular, tubular, they all will be gone. And this is the molecular classification, which tells what treatment to do. For example, triple negative, it has to be platinum salts or anti-EGFR or PRP inhibitors. Like that, the whole classification of the breast will be depending upon the molecular changes that are very helpful in therapy. Before knowing all these advances, we have to know some basic things. So normal histology, the breast is arranged in lobules. It's like a cluster of grapes, and the grapes are the functional units or lobules. And there are two types of cells when you go to the high power, the luminal secretory cells and abluminal myoepithelial cells. Why they are called myoepithelial? They have the property of the muscle and epithelium. That's why it is called as myoepithelial cell. And they are very helpful in pressing the luminal cells to express the secretion to outside. Like there are two types of cells, even in the stroma, there are two types. One is within the lobules, which we call intralobular stroma, and other one is interlobular stroma, which is more collagenous or more fibrotic. Whereas the intralobular stroma is more loose and edematous. And if you go to high power, you may see some plasma cells in the intralobular, and they do the IgA secretion in case if there is a lactation. So this basic understanding is very, very important, because in breast lesions, there may be only epithelial luminal secretory cells or abluminal myoepithelial cells, or there are some lesions where epithelial and myoepithelial cell will proliferate. And we have specific markers to identify this epithelial and myoepithelial cell. For the epithelial cell, we usually use the low molecular weight cytokeratin. And for myoepithelial cells, there are a lot of markers, but the most important marker is P63 and P40. How to approach breast lesions pathologically or under the microscope? We have to ask 4 questions. Is there proliferation in the lesion? Is there any atypia in the proliferation? Is there any invasion of the cells? Is there any history of metastasis, or is there any metastasis in the lymph node? So we have to ask these 4 questions, and depending upon the answers, we have diseases grouped. One is non-proliferative disease, and other is proliferative disease without atypia. And whenever there is a proliferation, as I asked you, you have to ask whether there is atypia or not. So it can be, the diseases can be classified into proliferative disease without atypia and proliferative disease with atypia. And the third question is invasion. So there are 2 possibilities. One is no invasion, and the other one is atypia with the invasion but no metastasis. And when you ask the first question, then you get the proliferative disease with the atypia, with the invasion, with metastasis. So these are all the 5 main patterns of pathological lesions. You have to see it in breast. And when I give you the examples, you may be able to follow better. The non-proliferative disease is cysts and mammary duct ectasia. The proliferative disease without atypia, it can be hyperplastic, or it can be inflammatory, or it can be granulomatous disease. With the atypia, no invasion, there are the borderline lesions where we call it as atypical ductal hyperplasia, atypical lobular hyperplasia, or atypical papilloma. And then carcinoma in situ, either it can be ductal or lobular in morphology. When there is invasion, we have to measure the invasion, and if it is less than 1 millimeter, we call it as microinvasion, and if it is more than 1 millimeter, we call it as invasive carcinoma. The metastasis can be regional metastasis like lymph node, or systemic metastasis like the other organs like lung, liver, brain. So this is also known as pattern analysis of breast lesions. And this pattern analysis is gaining importance in almost all the organs now, but it is very commonly used for the breast. This you have to understand. And breast lesions happens in a spectrum from normal to physiological change. As I told you in the previous slide, it's a non-proliferative lesion without atypia, proliferative lesion with the atypia, carcinoma in situ, microinvasive carcinoma, and carcinoma with a lymph node and a systemic metastasis. Why we have to know the spectrum? The minute you get the cancer, there is failure in our system. We have to identify the patient before developing into the cancer. For example, in the proliferative stage itself, we have to identify. And there are risk of malignancies depending upon whether it is proliferative and whether it is atypical. For example, when there is proliferative lesion with atypia up to carcinoma in situ, there are 8 to 10 times risk of malignancy in that particular patient. But as you know, prevention is better than cure. So we have to identify the disease before it goes into cancer. Coming to WHO 2019 breast lesions, there are 7 main types: epithelial lesions, fibroepithelial and haematomatous, tumors of the nipple, mesenchymal tumors, hematolymphoid tumors, tumors of male breast, and genetic tumor syndrome. So these are all the 7 broad headings you have to know. Then under each heading, you have subheadings. For example, epithelial tumors of breast can be benign epithelial proliferation and precursors, adenosis and benign sclerosing lesions, like that. And these are all the members of benign epithelial proliferation and precursors, adenosis and benign sclerosing lesions, and adenoma. This is the next step, and you can see the orange letters. These are all the headings of the current slide, and this is the previous slide, and this will be the next slide, so that you can know what are all the major headings, and these are all the members of that lesions. For example, papillary neoplasms, it can be a papilloma, or duct DC, papillary DCIS, or encapsulated papillary carcinoma, solid papillary carcinoma, or invasive papillary carcinoma, like these are all the members of epithelial tumors of the breast. These are all the other members of epithelial tumors. These are the members of fibroepithelial tumors and haematomas of the breast, tumors of the nipple, and tumors of the male breast. Mesenchymal tumors of the breast, like any other soft tissue, any tumor can happen, but vascular, fibroblastic, myofibroblastic, peripheral nerve sheath tumors, and smooth muscle tumors, along with adipocytic tumors, are more common. Hematolymphoid tumors and genetic tumor syndromes are enumerated in this slide. Now we are moving to what are all the updates in 2023, and mainly in the WHO classification, and it is in 2019 that 5th edition of the breast blue book was in 2019. The 7 changes are: what are all the subtypes of cancers included in infiltrating breast carcinoma, not otherwise specified. You all know we should not call it as infiltrating ductal carcinoma. So it is infiltrating breast carcinoma. Oncocytic, lipid-rich, glycogen-rich, clear cell, sebaceous, choriocarcinomatous, and pleomorphic subtypes. Carcinomas with osteoclast like stromal giant cells, and carcinoma with melanocytic features, they are all included in IBC-NST. And these are not, previously they are called as oncocytic variant of IBC-NST, but the terminology variant is now used only for molecular and genetic changes, and here they are known as pattern, oncocytic pattern, lipid-rich pattern, or lipid-rich subtype rather than variant. The medullary carcinoma, now renamed as invasive breast carcinoma with medullary pattern. the neuroendocrine tumors, they are telling first to rule out metastasis because primary neuroendocrine tumors are very rare and they are not like in other organs. Here it is well differentiated neuroendocrine tumor, grade 1 and 2, carcinoid and atypical carcinoid like. And there is no grade 3 neuroendocrine tumor in breast. And neuroendocrine carcinoma is known as poorly differentiated neuroendocrine carcinoma, and that is further subdivided into small cell and large cell neuroendocrine carcinoma. There are two new entities included in 2019 Blue Book: tall cell carcinoma with reverse polarity and mucinous adenocarcinoma. The liposarcomatous, well-differentiated liposarcomatous component is not a criteria for malignancy in Floyd's tumor. Previously, when you see well-differentiated liposarcoma, it's one of the criteria for malignancy. Now it is not, because the molecular changes are not supporting the malignant nature in well-differentiated liposarcomatous tumors. There are two things that affect the treatment. One is PD-L1 clone 22C3. If the combined positive score is more than 10, we have to use anti-PD-L1, pembrolizumab. And how do you calculate the combined positive score? Number of PD-L1 staining cells, including tumor cells, lymphocytes, and macrophages, divided by number of viable tumor cells into 100. And Ki67 index, clone MIB1, if it is more than 20, again, they give specific treatment along with endocrine therapy in hormone positive, HER2 negative, node positive, early breast cancers. So these are all the 7 changes that are new now.